and I might be talking about how patients make decisions in a minute, but we'll go on. This is a fantastic public health strategy that San Diego produced, and I like it because it goes through a very simple technique. 3 behaviors lead to 4 diseases, lead to 50% of your deaths within a population. It's a public health message that they used, and they have reduced their deaths in San Diego by some 20 or 30% just by going on those 3 behaviors. No physical activity, poor diet, tobacco and alcohol. It's a great public health message, and you can accept it as a public health message, or we can accept it as part of the perioperative program. And this is the sort of way we're looking at perioperatives and perioperative programs and preoperative status at the moment, and risk assessment. And you can see there collaborative decision making. Mike's just talked about that at one end of the spectrum, but collaborative behavior changes at the other end of the spectrum too. And we have all these other things that we've got to sort out: perioperative frailty, perioperative disability, looking at the ADL, social support. We've got all the comorbidities that we've talked about today, and we're trying to get a handle on and work out how we can move it on. And then lifestyle changes. Why the heck should we bother about lifestyle changes when we've got all these other things to do? I think that's why we have to do it, because this is the teachable moment. And we can either teach it or we can miss it. And the joy about perioperative processes and the preoperative assessment is that the patients that are coming into us have a much higher prevalence of these lifestyle issues than the general population. So it's a captive audience. We have effective interventions. We have higher quit rates if you actually introduce interventions at that time, and they certainly have long-lasting effects. So we've got the wherewithal to deal with these problems. It's just the time and the effort we have to put into them to sort out the problem. So the real questions here are, how can we convince people what is good for them? The paternalistic doctor, we have to convince people. Or perhaps the question is, how can we promote a healthier perioperative lifestyle? I'm going to take an example of alcohol, just because I like it. I'm from the north, but it's also because we've been doing a study over the past 3 years, commissioned by the HTA and IHR, on orthopedic patients, trying to look at the feasibility and looking at a pilot study of trying to develop a perioperative intervention for alcohol reduction before surgery. And we've just completed it. We're writing up the report as we speak. So it's just a little bit of data on it. It's a very qualitative study, and as a feasibility study, as you expect, there's not a lot of data in terms of outcome, but the side of the things that are really important is about behavior and change and the patients. So the first thing we had to do is look at the general evidence base, and don't believe everything you read. You've got to really get into your evidence. So this is the statistics on alcohol in England in 2018. And we think of alcohol as it's a young thing. Everybody's falling over after they get drunk on a Saturday night, certainly in the big market in Newcastle. But it's not actually. Weekly consumption by age. The high-risk drinkers are actually 55 to 74, exactly the age group that we're looking at of our surgical patients. And the ones who are coming into hospital with admissions for alcohol are not the young guys, they're the old guys, the 55s to 75s. So it's a captive audience that we are dealing with all the time. They're the problematic alcohol drinkers. And then you look at some of the data contextually in terms of surgery, and you'll see that there's a rather strange dynamic in terms of how much alcohol you intake and your risk post-operatively. So here you are, here's no non-drinkers, and here's the highest risk drinkers. You can see there's a dose relationship there. When you get to the low risk and the non-drinkers, actually your risk goes up, which is great for those people who like alcohol. But actually, it's this reduction that we should be talking about. And the difference between reducing drinking and stopping drinking in a patient's behavior is miles apart. So the most important thing about implementing any process is that you develop a consistent message. And that has to come from everybody who talks about that message. We talk about healthcare role models. We haven't been the best role model in the world in terms of doctors. This is just a questionnaire, a bit old now, 2004. But we think we do it, 30% response, 90% ask about tobacco, 100% believe that patients should abstain from tobacco. Most think it's their job to ensure compliance, but only 30% and 58% do it. So we're not very good at it, and actually most of us are not that brilliant role models. But if you look at, and this is just something from the College of Surgeons to say that actually we should be training our trainees to actually start to look at how they might talk to their patients about reducing this is alcohol. But we also asked our patients about what they what they think about stopping alcohol. And there's lots of different qualitative issues, but the most important thing I want to just bring out on this slide is the credible source. Patients didn't expect behaviour change support from a consultant, but the message to engage had come from the top. That means anybody who's trained in doing these behavioural interventions can do it, and the only thing about consultants who are not very actually good at it, as long as we're at the top, that's fine, but we don't have to do it. You also have to define the population. So in the study that we've just done, we've approached in the feasibility and pilot study, and we've screened lots of people. The most important thing is the eligible population within each arm of the study or component of the study is about the same. So we see about 20% of our patients are risky drinkers. So it's a pretty consistent level. Make the perioperative connection. Most patients don't understand that drinking is related to complications post-operatively. And what we got into a real problem, we call this study Pre-op Birds, which is a little bit difficult in terms of most of the people on the study were ladies, so it was a bit worrying. But it started off as behavioural intervention for risky drinkers for surgery. Patients hated the risky. They did not want to go into the study because they didn't like to be called risky. Now, in general terminology in alcohol, risky is a set criteria. But we had to reduce it to reduction for surgery because of the data and also because the patients didn't like it. So listen to your patients and make that perioperative connection. It's about reducing for surgery, not being risky. And then use your ready-made tools. So there are tools out there for alcohol particularly, and there's lots of tools for stopping smoking as well. But alcohol screening, and these are the questions that you ask anyway. How often do you have a drink? How many units do you drink on a typical day? And how often do you have a binge session? Now, that one, I think, the third question is different, but the other two we ask in the pre-assessment clinics anyway. So you can use these tools to score, and these are recognized tools in terms of alcohol intake. And then when you get the screening and you get your population that you've seen, you need a simple intervention. Now, there is a lot of evidence on brief advice, 30 years of research, 24 systemic reviews showing that brief intervention works to actually reduce alcohol intake. And so, again, there's an intervention that's already there that you can pick off the shelf and hopefully contextualize it and put it into the perioperative process. And then, of course, you get human behavior. And that's where it all falls down. Not. Humans are very irrational people. And the most important thing about humans is, firstly, the barriers they put up to everything you want to do. And a lot of them are sensible, but a lot of them are just practical issues which you can look at, personal issues and education. So you've got to define what the barriers and also what the facilitators are to these people doing something and changing their lifestyle. Social norms is also something. Remember, you are a tiny, tiny component in their life. They've come, an important component, but they've come for an operation, but you are a tiny component in their life. So social norms, the relatives, the family around them, their environment around them is much more important than you. So also you've got to start thinking about how you develop idea of what they do in their normal environment. And surgery school might be one way of doing it, prehab might be another way of doing it, but there's lots of ways you have to start to think about their social norms. The other thing about humans is, unfortunately, we're programmed to avoid loss, and that loss is loss of time, comfort, and convenience, rather than get pleasure from gain. So if you stop drinking, you might actually gain benefit in the terms that you don't get your complications after surgery. And also, it's short-sighted. So immediate losses rather than distant losses of future illness are important. So humans start thinking in short-term, not long-term. So to sort out human behavior in a very, very basic way, what we've got to do is accept irrational behavior that happens, understand the barriers, provide and promote the social norms that we know about, promote the gain rather than the loss, and bring forwards the benefits of stopping whatever you want to stop, changing your lifestyle. And if you can't change the person, you could try and change the environment. So behavior is about, if you can't change the person, you've got an environment change. And we're seeing this all the time in hospitals now. So you go into a hospital, and on some of the visits we've been on, you go in and you see some healthy fruit at the front of the hospital, and that's all very nice. And you put away the horrible healthy eating or the alcohol. So you change your environment for the patient. So the conclusions of this study at the moment is that there is a feasible alcohol intervention. It's there. It can be run, the study has been run through a perioperative clinic, and it's been nurse-led. The screening intervention is readily available. You have to avoid certain, contextualize things and avoid some certain pejoratives. Change some of the connotations of units and drinks that people don't understand, and look at motivational issues rather than volitional. The study recruitment was moderate because we had to change that influence over reduction, but the retention rate at 6 months for these patients is huge. So if you get the message right, you get the intervention right, these patients stick with it. We do need a larger trial, obviously, as always said. So the summary of the whole thing here about lifestyle change, we have, as a perioperative group, got to embrace this moment. It doesn't occur every contact of the patient, but it certainly occurs in pre-assessment. Review the available evidence and don't believe everything you think about the evidence. Some of it's wrong, and some of it needs to be interpreted in a different way. Provide a consistent message. That is the most important thing. So if you're saying something about stopping and someone else is saying something we just have to reduce, that's not going to work because they get mixed messages. Use the available tools available to you, and there's lots of them out there for all these lifestyle interventions. Alcohol is particularly a good one and a good example. And try and start to think about human behavior. And it goes back to some of the things that Mike said about shared decision making. We've got to start talking to patients and understanding the barriers, the facilitators, and all the problems that humans have in making decisions. Thanks very much.